Well, welcome back to this channel, and welcome back to Dr. Michael Cohen, who's in a slightly warmer climate than I am compared to our relative attires. Dr. Cohen, thank you for coming back.
Thank you for having me, John. Actually, today it's very stormy, windy as hell, and we've also experienced a little bit of the aftershocks from the Turkish earthquake here. So,
yeah, indeed,
sad.
Yeah, indeed, yeah. It's a bad situation. Now, today we're talking about repurposed drugs, and we both agreed we wanted to talk about this because there's quite a few drugs that are well out of patent now. They might have been around for, well, anything over 15 years, really, to be out of patent, 20 years, 50 years. And I was just thinking of some examples. I mean, aspirin is a repurposed drug. We originally used aspirin to treat fevers. Then we found it was treating pain, and then we found it was reducing platelet viscosity. Morphine, of course, has a wide range of applications as well as simply as a painkiller. Viagra was actually developed as a drug to treat angina with its alterations of blood flow. And famously, of course, prednisolone was repurposed to treat the inflammation associated with COVID, acute respiratory distress syndrome. So repurposed drugs can be very cheap. We know the toxicity, the toxicity profile, and we're used to using them. We know the doses. We'd like to use more. And Dr. Cohen, I think you want to bring us a particular example today. What example did you want to bring us?
So another word for repurposed drug is actually orphan drugs. So an orphan being obviously a child without parents, and these drugs are drugs that seem to have no place in the world. They're sitting on some shelf somewhere and nobody's really been using them for anything other than their initial purpose. And about 8 years ago, I came across a drug which I've known about called Naltrexone, but the way in which I understood it was that when it was given in low doses, it was then an orphan drug, meaning it's normally prescribed in doses of between 50 to 200 milligrams a day. It was originally, I think it came out in the 1960s or so, maybe even before that. It was used for heroin withdrawal to basically prevent the morphine from affecting the body, so a person taking morphine couldn't actually feel a high, and it would basically help them to wean off heroin addiction. It's also been used for alcohol withdrawal. What's interesting is that in around the time of the AIDS epidemic in New York, there was a doctor called Dr. Bernard Bahari, and he started playing with Naltrexone. Instead of giving it 50 to 100 milligrams or more, he started giving it in doses of half a milligram, 1 milligram, usually settling on about 3 to 4.5 milligrams and going as high as 6 or 7 milligrams. And he found that at the time there was only one drug for HIV, which was AZT. And he was finding that people who were taking this drug, many of them did not go on to have AIDS, which is the actual illness. So HIV is the infection. AIDS is what you're trying to prevent happening, the autoimmune. I've forgotten what AIDS stands for a moment. But
acquired immune deficiency syndrome. Where
acquired immune deficiency syndrome. Sorry, I've got autoimmune in my brain at the moment. And so he found that by using this drug at very low doses, it actually seemed to prevent the progression onto AIDS-defining illnesses. Now, what happened over the years is that this drug, Naltrexone, passed its patent many years ago. So it's a cheap drug. And people started playing with it at these low doses for a variety of different illnesses. And it's been used in Crohn's disease, which is an inflammatory bowel disorder. It's been used in other autoimmune diseases. It's been used in various skin conditions. It's been used in fibromyalgia. It's been used in multiple sclerosis. And in the last few years, it's even been found to be useful in certain cancers as an adjuvant therapy for certain cancers. So it's got a very interesting history to it. It's a very, very safe drug. And I used it on a patient initially about 8 years ago. There's a video on my channel about it, which people can look at. I used it with someone who had COPD, a chronic obstructive pulmonary disease, which is basically chronic lung disease. And it had really a dramatic effect, and I'd never seen anything quite like it for such a safe drug. And so I've played with it over the years with different patients with mine who are willing to try something different and safe. And I've had some people it doesn't really do very much for, and some people it does those really dramatic effects. And so I wanted to speak about it, especially in the context of what we've been seeing in the last couple of years with COVID and long COVID, or post-COVID syndrome. And that's why I wanted to bring it to you today.
Now, this drug is in the British National Formulary, which is the definitive text of all drugs. And the initial starting doses are 25 milligrams per occasion, going up to 50 milligrams. So we're talking about really quite tiny doses here, aren't we, of this drug?
Yeah.
Which I like the sound of, because smaller doses could well be safer.
Well, smaller doses are safer, but the interesting thing about this drug is that when it's given when you're trying to use the smaller doses, and then people say, oh, well, it seems to be working, well, I should just increase the dose. So it's not as simple as that. The actual principle through which it works is called the Hometic principle. And hormesis is exactly that different doses of the same drug can have very different effects. And so if you were to surpass these low doses, it would actually stop working for the purposes intended. So the idea is actually that it stays at this low dose. There are also other uses of it where it can be given at very low doses and ultra low doses, and they're used in anesthesia and pain medicine. So this drug given at low doses has anti-pain qualities, analgesic properties. It can even have antidepressant properties, anti-anxiety properties. It has a whole raft of different properties, and the mechanisms through which it works are very interesting. Instead, what it does, it kind of tricks the body. It tricks the body by blocking the receptors, but because you're giving a low dose, instead of blocking the receptors of the opiates, of morphine, etc., for 24 hours, which is what you would normally aim to do, and then they just take a tablet every day, what this does is it blocks the receptors for just about 3 hours, let's say. And this tricks the body into thinking that there are no receptors, and it has to upregulate. It has to start producing more receptors. So it produces more receptors, and it also increases what's called the opioid axis. So basically, things start working more in the direction of the body producing more of its own endorphins and enkephalins. And what are endorphins and enkephalins? These are the substances that the body naturally produces when, let's say, you go for a run. So if you talk about the runner's high, that's what happens. They go for a run, the body produces these substances, and these have the similar or the same effects as to what we're doing with low-dose naltrexone. So a person feels generally better. It can improve various parameters, including mental state, but also physiological state, can reduce inflammation. And that's what this drug does, except for without going for a run, let's say, or going to the gym. And so taking it on a daily basis can have quite a profound effect on a person's health, especially if they've got an autoimmune disease, let's say, or if they've got chronic pain, possibly if they've got chronic fatigue. And that's why it's an interesting medication, because it's so safe as well.
So what's happening here is we have these receptors all throughout the body, in the brain and the central nervous system and other places. And the body makes a substance that goes in it, an opioid type substance that goes in it. Endorphins and enkephalins are the example. So the body's making those. And the way that morphine works is it's the same shape, and it fits into these receptors and it stimulates these receptors. So what we're actually doing is we're blocking these receptors. And that's making the body think, heck, I haven't got enough going on in my morphine pathways. I better upregulate this morphine, this endorphin pathway, make more receptors. So whatever endorphin and enkephalin the body's making, it becomes more sensitive to. So it upregulates the effects of these. Now, obviously, this discussion that Dr. Chron and myself are having is completely academic. We're not prescribing any drugs for anyone. It's purely for interest. But I must say, seeing there's only you and me here at the moment, Doctor, I could do with feeling better some of the time. I could do with having lower levels of anxiety some of the time. And it sounds like this might be an interesting way that could be studied to promote my feelings of well-being.
Well, one of my dreams is actually to find a way to raise enough money to do a proper study. As you know, research studies are expensive. I'm not a researcher. I'm someone who tries to think about what I see and apply it to my daily practice and try and let people know about it. But it would be very interesting to have the proper studies done. Because this is an orphan drug, it's also lacking financial support. So, like, unfortunately, many compounds in medicine that are sitting on the shelf that could have very good effects, there's not much of an incentive from a financial, economical point of view to do such research. And it really would take a body like the NHS or the National Institutes of Health or something like that to fund studies like this. And I think they can be really worthwhile to do these studies. Obviously, there's a lot of competition from other pharmaceutical companies that actually can make profit out of drugs. But I'm bringing up this subject because it's such a cheap drug, because it's so safe, and because there is a lot of actual clinical use of it. It's just that most people are not aware of it, and most doctors are not aware of it, unfortunately.
So this drug is not immunosuppressing. It's an immunomodulating drug. Can you just draw out the difference between the two for us, the difference between immunosuppression and immunomodulation?
Well, immunosuppression is something that happens in the event, for example, when somebody is receiving a medication such as a steroid, such as prednisolone, prednisone, or dexamethasone. These drugs actually suppress the ability of the body's immune system to respond to inflammation, or well, actually suppress the body's production of inflammatory chemicals. And as a result of that, their disease is, let's say, put into a less active and aggressive state. However, it's not dealing with the underlying process, and it's actually not working, let's say, positively on the immune system. It's working on the immune system. What Naltrexone does through the effects of creating more endogenous, so morphine that's produced by the body as opposed to coming from the outside as a drug, is that it actually modulates the effects of the immune system. It directs the immune system in a better way. And so the person's own immune system doesn't overreact or underreact to a given problem. And as a result, you can reduce inflammation and just reduce disease activity, and sometimes even probably, I don't want to say cure, but certainly improve the overall state of health of the person without
kind of an immune optimizer.
Yes, that's a good way of saying it.
Rather than a good way of saying it. Yeah. Now,
correct. Correct.
I understand that the effects on the upgrading the endogenous opioid system, that makes sense. You've got more of these lovely opioid type chemicals floating around, but physiologically produced. But the anti-inflammatory effect, how is that facilitated in terms of the pharmacodynamics?
Well, the drug works to cause it. Firstly, in the central nervous system, so in the brain, it actually affects the glial cells in the brain, and as a result of this, there are receptors called Toll-4-like receptors, and by antagonizing them it actually causes a reduction in inflammatory compounds, IL-6, for example, and a couple of others that don't come to mind at the moment. And as a result of that, you have down the road, you have a reduction in inflammation, and that's the way it works in that sense on the central nervous system, but also on the peripheral nervous system, and also in other parts of the body, in the gut, and the lining of the lungs. It also has similar effects. Now, obviously, we don't know everything about how this medication works. What we do have a fair bit of experience with is seeing how safe it is, and that many people can derive benefit from it.
Let me just see if I've got this bit, if you don't mind. So the glial tissue is tissue cells in the nervous system, but it's not the nerve cells. It's the supportive tissue. It's the other tissue.
They're the supportive tissue. They are the supportive tissue. Exactly.
Insulate and provide immune protection.
Yep.
So
yes,
if these and these glial cells can produce something called this toll-like receptor 4, and that toll-like receptor 4 will stimulate inflammatory chemicals. Whereas if
as opposed to if you block it,
so the Naltrexone is inhibiting these receptors. Therefore, it's reducing the amount of these pro-inflammatory substances made. So you're reducing the inflammation within the central nervous system and other places.
Yeah, and probably down the road from the central nervous system, because the central nervous system also controls. Obviously, that's why it's called the central nervous system. It's controlling many other aspects of the body.
But this is also down-regulating or moderating inflammatory processes, as you've said, in the lining of the lungs, as it was so effective in COPD. So it's down-regulating pathological inflammatory responses in different parts of the body.
Correct. And in addition to that, it does create some degree of, I'm going to say an improvement in subjective well-being. So a person feels better on it. And that's because it has other neurological effects, good neurological effects in general.
So for some of us that have got sort of almost a chronic low-grade depression, you never feel quite like you never quite feel as bouncy as I'd like to feel. It could be because I've got chronically low endorphin levels. That's a feasible mechanism.
Yes, that would be a very feasible mechanism. It's quite likely to be true for many people. And one way in which you could test it is go for a run, go do some exercise. You'll find out. Right? If you feel significantly better, I mean, this is one of the classic things that. Why what? Sorry.
Why would I feel better after going for a run? What's happening in my body?
Well, so in your body, you'd be producing endorphins and enkephalins. So these substances that exactly do what Naltrexone does, which is to cause the body to produce more of its own endorphins and enkephalins, but without going for a run. So you might be injured from going for a run, but you would probably be feeling better. You'd be on a bit of a high. And it's one of the classic things that I use with my patients who've got anxiety or depression. Tell them go for a fast walk, go for a run, do some exercise. And although it's difficult to initiate those things, once they do it, they actually feel regularly a lot better. And I see it all the time. People who often don't, I don't want to put people on medications. And I'd much rather say, listen, go do some sport, do some other things. And it really can help a lot of people. And that would be the kind of mechanism that would work. Yes.
But part of that is the exercise is inducing the body's own opiates. And I suppose if you did take the low dose Naltrexone, because you've sensitized your opiate system, you would get an even greater effect from any amount of exercise that you did from the opiates that were produced.
It's possible. I don't know who's studied that, and I can't say one way or the other. I just don't know, but it's very possible that would happen. Yes.
So if I would start taking low dose Naltrexone as a mood improver, I'd probably be taking 2-3 milligrams a day, something in that order.
Probably in the region of 3 to 4.5 milligrams a day.
It's a very, very low dose, isn't it? Really is quite impressive that
Yeah.
would
And I do
that would work.
I do see people respond. Yeah, I do see people, as I say, responding at even 0.5 milligrams, half a milligram, 1 milligram, 1.5 milligrams. I have to play with them a little bit to see what works for each person, obviously. And I have to balance this off against the potential side effect. And the only two significant side effects that people get is that in the beginning it can cause some people to have some insomnia, so it can make it difficult for them to sleep for the first week or two, but generally that one passes. And the other interesting one is it causes vivid dreams. Now, most people who get the vivid dreams have very pleasant vivid dreams. Some people do experience unpleasant dreams and very visual dreams. And the other thing to say is that although in general it's thought that it can cause insomnia, for some people it actually makes their sleep quality much better.
That does kind of make sense, because for the first week, even though it's a small dose and it's a partial antagonism of the system, it's a partial blocking of the system, nevertheless, to begin with, until the body compensates by producing more opioid receptors, you'd have an overall down regulation of the system, so there'd be less opiate activity in the body while the upregulatory process
until it builds up. Yes.
Yeah. How long before I would feel significantly better, do you think? If I'm a respondent to this
I
treatment?
honestly don't. I would say that I can only go by my personal experience of using it for patients. And I can say that in general, I try to get people to use it for at least 1 to 2 months to see how they're doing. That doesn't mean that they don't have effects prior to that. A lot of people do get effects much sooner than that. But let's just say I wouldn't tell someone that this is not working until I tried it for at least 2 months, possibly 3 months for any given condition.
But that's the same for completely different classes of drugs like selective serotonin reuptake inhibitors that are going to the Prozac type drugs that are going to take quite some weeks to alleviate depression and anxiety.
They can do. Yeah, but for some people they respond in 4 days. So it's people. There's a large degree of variability about these things.
So we've got this poor orphan drug sitting there, but it's got the potential to treat a range of inflammatory conditions: multiple sclerosis, fibromyalgia, chronic obstructive pulmonary disease, Crohn's disease, possibly even some others. Improve sleep, give us really nice dreams, and reduce my low mood and anxiety. So what I would like to do is call on all big pharmaceutical executives who we know watch these videos, by the way, and call on them to organise large-scale, randomised, double-blind controlled trials. Because what Dr. Chron and myself have talked about on this video really is a hypothesis. We're kind of at that level. So we want huge trials involving several countries, tens of thousands of patients, and let's get definitive data on that. But given that's not going to happen, because they can't make any money out of it, we really need an alternative way of doing this, whether it's governments funding academia, whether it's crowdfunding, whether there's a philanthropic billionaire. I believe there are a few in the world watching. This is a way to potentially help the well-being and the mood of millions, if not billions of people. That is a safe, as probably safer, I think it's safe to say, than other treatments that might be used.
Well,
and
I'll say that. No, I'd like to say that it's definitely one of the safest drugs that I've ever given to anybody, and I don't like giving out medication at all. Whenever I can avoid medication, I'll avoid it. But if I have to give something, this is on my list of very few medications that I have almost no hesitation in giving to patients given these doses.
Well, I'm just fascinated by that, Dr. Chron. I must say, totally fascinating. Obviously, take no drugs at all based on what we say. Only take drugs prescribed by your own doctor or your own prescriber. This is a hypothesis. We're appealing for research on this. We're certainly not advising anyone take any drugs at all based on what we say. And I take it you would agree with that.
I would. I'd also say,
proviso.
in light of absolutely, but I'd also say in light of the COVID pandemic and the vaccines as well, I think and there are a couple of papers also that talk about its use in long COVID, and it has been used in a fairly small trial, albeit, but with some fairly impressive effects compared to anything else. And if we look at these trials in isolation, it's easy to say, well, the effect of this isn't that much and it's not curative or whatever. But you could also start saying, well, if I was to do this and I was to do this and I was to do that, I might have a very significant effect. Now, we know that there was certainly one trial for low-dose naltrexone to look at its safety and efficacy, so how safe it is and how effective it is in patients with long COVID. And it did show some very significant effects on this cohort of patients. And it's definitely it's a springboard to think, well, what else should be being done here? Should we be doing larger trials, which I do think we should be doing? And I really see no downside to using this in nearly all patients, nearly all people. So that's another thing that I would call for, would be to see if we can get support to do something like that. Certainly to spread the awareness of this medication.
That disclaimer was supposed to be my wrap up there, actually, but now you've mentioned that, there's an awful lot of people suffering what we assume is spike protein inflammation, whether that's from COVID, whether that's from vaccine problems. The amount of people suffering from long-term, basically what we believe to be neuroinflammation, is probably in the millions around the world, and this is a potential low-grade, essentially safe management strategy. And it really grieves me that it's not being investigated. But that could change as a result of this video. We can hope.
That would be good.
It would be good. Great, Dr. Cohen, as always, fascinating. Thank you very much for your insights and the benefits of your experience, and especially good to see how this has worked so effectively in patients that you've treated and supervised personally. So thank you, and hopefully Dr. Cohen will choose to come back and for future videos. Always look forward to it.
I'll think about it.
We'll see what we can arrange. Okay, thank you. Thanks. Bye.
Take care.
But thank you for watching.
Bye-bye.
Everyone.